Awesome. Thank you. So welcome, everybody. We are so grateful to have you here for our sixth and final cafe in the series on sustainability and strategic partnerships as part of the future of care for children with medical complexity. Today, we have some fantastic discussants. We have Dr. Rahel Berhane, Dr. Schiff, Dr. Rich Antonelli. Next slide, please. You can read their most excellent bios on our website, but we like to make sure we really use our time efficiently. So we are going to share that link with you in the chat and continue on. Next slide. And please know that Jeff and Rich are with the Enhancing Systems of Care for CMC Coordinating Center, and Rahel is with our former CMC coin, upon which this series is predicated. And she also, Team Texas is represented as a demonstration site with the Coordinating Center. So all around, it's such a fantastic group we have. Next slide, please. And we are so grateful that this series is funded by the Lucile Packard Foundation for Children's Health. Their support, their thought partnership is excellent. They have fantastic resources. Please check them out. Next slide, please. We really were intentional with this particular cafe to make sure we had objectives in mind, because sustainability is so multidimensional and complex. So first, we want to make sure that we can understand, start to seed the beginnings of helping you to be able to do these four things. Understand how to identify meaningful, oops, I think someone might need to be muted. I can hear someone. Let me see if we can mute some folks. If you know that you are not muted, if you could do so, that would be great. Awesome. Thank you. Understand how to identify meaningful opportunities for effective sustainability solutions through family co-design. Begin to identify approaches for moving from the small wins to broader system sustainability of humanistic care. Learn strategies for building trust and partnerships across stakeholders, and develop practical steps for sustainability planning. Next slide, please. That's not much to do. We'll get it done, no problem. And then just to remind you, for this series, we are looking to foster interdisciplinary dialogue among participants interested in meaningful systems improvements for CMC. We have 60 minutes. Family partners co-lead in every session, and all the discussion questions we use and analysis out of what you share, it's all created with our interdisciplinary faculty. Next slide, please. And who we are is truly interdisciplinary as well. This top line of circles that you see, that is, there are people that are very heavily represented in our group. And then the bottom row is the small but mighty, also here joining us. And so all together, we truly represent so many different vantage points from the system. And that's what it's going to take to be able to address these complex systemic issues. Next slide, please. We are all going to be able to use chat. You can raise your hand. All ways you can participate are welcome. Next slide, please. And of course, when you are not speaking, please mute. And we'd love, when we're doing the discussion, if you are able, and we encourage you to put your camera on so we're able to see each other and really engage in that dialogue and discourse. Next slide, please. This is our capstone. It's our sixth and final cafe. And we were talking to our faculty and our family faculty, and we've been trying to say, what do we need to do here? And there are two through lines of this series that are so critical that we want to make sure with this, we're really hitting it home. Humanistic care, radical family partnership. You know it when you see it. This is someone said in our discussions, it's just so easy to talk the right talk. When you see the walk walked, it's really unmistakable. When family expertise is included, it leads to more efficient, effective solutions, and when it's being truly valued. Another quote from those discussions we had in planning this: everyone in my experience wants to do the right thing. There just isn't always a shared understanding of what that is when the outcome from the family perspective isn't represented. So we want to be operationalizing the how of the process. Next slide, please. And that means we really want to talk about here, what are we sustaining, for whom, and how? Next slide, please. So we're going to shake it up. We're going to be in the full group. We're going to really highlight the process of co-design so you can think about it and how to approach it with sustainability. And Rahel's going to give a specific example about syringes, but as she says, it's really not about syringes. It's not about it. This adapter being given as code so it can be built, it's not that. And we're going to distill key elements of sustainability with Rich and Jeff. And it begins to assemble the start of a playbook for everybody in your own ecosystems. Next slide, please. So now I'm going to hand it over to Rahel so that she can start digging in with some really fantastic work that she's been doing. Thank you. Rahel, take it away.
Thank you, Bethlyn. Mitra, if we can go to the next slide. So as Bethlyn mentioned, I'm a pediatrician and I serve as a medical director of a clinic in Austin, Texas. So the clinic is one of the sites for HRSA-funded 5-year demonstration project. It's enhancing systems of care for children with medical complexity. It brings, stakeholders together and pilot potential improvement projects. So as part of this project, right at the outset, we organized ourselves into subgroups, and one of which was a policy analysis work group. And it had representation from families and the MCO and Health and Human Services, and of course the clinic. And early in the year, one of the questions that the policy analysis team had was primarily directed at families: prioritize the most significant challenges in the care of your children that can be impacted by a change in policy, whether it is policy from the health plan or policy from Medicaid, from Health and Human Services. And as expected, a whole lot of a list of things came up. But the parent members of the policy analysis subgroup proposed that the question be taken up to the larger family work group to get more input and to help prioritize this list. And surprisingly, challenges related to supplies, especially syringes, came up as a big pain point. And I confess to myself and to many of us, initially it felt like it seemed too niche of an issue. And but to their credit, the policy work group did not pivot away, did not dismiss this, did not say, well, let's think of big, high-level policy things, just drilled down to learn more and convened more sessions. Next slide. And the responses, as the families told their stories, were pretty mind-blowing. They were just one example after another. Like Medicaid supplies 10 syringes per month, and each syringe does not last more than a couple of uses. And my child has 15 medications that have to be given 3 times a day. And there was another story where the syringe tip does not fit. The DME delivers these connectors that don't work well, leading to accidental disconnection and spillage. And there was another story about the rubber stopper on the plunger that does not last. And after a few uses, the rubber part pops off, which causes the medication to be lost and spilled. And then the syringe is unusable. There were stories about the DME sending syringes with labels wear out after 2-3 washes. Families tell us how they have to put tape to make sure the right quantity is drawn out. There are stories of syringes that don't fit the special vial that the medication comes in, so the medication has to be poured out somewhere else and been pulled up. And then more stories about unusable syringes, boxes and boxes of them being sent, and the family essentially has resorted to ordering the ones that work and paying for them out of pocket. So next slide. And we had a separate project as part of this same improvement work called Photo Voice, where parents were encouraged to document by pictures their daily lives. There was no communication between the policy analysis work group and what the folks who were doing the Photo Voice project were doing. But we were surprised that syringes made an appearance even in some of the pictures of their daily lives as well. Go to the next slide. There is one parent where she had a picture of a coffee and a mug and all of these syringes, and desperate for sleep, but my girl needs her meds, coffee for me, meds for her. Next slide. And another one where a parent has put all of this syringes and stated that these were the bane of her existence, washing these syringes. So for me, this exercise, it's been the most remarkable revelation for me. Two things. The first is, as families shared their stories, and as we later on convened with the larger policy analysis work group, what they go through in such exquisite detail. The most surprising thing for me was how those of us who were listening were pulled into their daily reality, as though by like a literal magnetic force. It felt that everyone listening, whether it was the HHSC person or the MCO rep or the academic people or the data person, whatever, were brought into that plane, the daily lived reality. And it was like, man, this is hard. This is just hard. There's got to be a different way. So this was the most powerful realization that when the problem is understood, rooted in the daily reality of life lived, the policies that we come up, the question that we ask to figure out how to solve these problems are going to be directed in the right way. The second thing, and maybe I have one slide, was that it was remarkable to me how the families also shared the solutions. The particular adapter that they have figured out works for all different kinds of syringes. And also that is sort of the granular level of the problem solving, but also systemic solutions. How might we organize this issue? How can we set up a system for low dollar supplies that is accountable, but also allows families to get what they need without all of this rigmarole, all of this paperwork on writing letters of medical necessities and doing peer-to-peers to justify, a certain brand of a syringe. So again, I think as Jeff and Rich lead us into discussions about how to create sustainable systems and sort of the macro level, this is sort of the story that anchors it is we have to make sure that it is rooted and informed by the lived experiences of the families and in a system that respects their expertise and is highly motivated, sort of emotionally motivated to figure out a solution that works. So that's kind of what I wanted to share as we got into these discussions, sort of radical family partnerships and humanistic care. This, for me, was a good example of that.
Rahel, thank you. I was wondering if you could highlight a little bit when we were planning for this and discussion, there's something that you were sharing that was very powerful around if what we sustain, in order for it to become sustainable, having it being built on trust of families and around the expertise that they bring. Could you speak to that a little bit for everybody?
Yeah, I think, as I told you, when you hear the stories, it is everybody's sort of, we need to solve this. This is hard. We kind of were literally brought into the room where they're doing these processes to help with their children. Now, the traditional way is sort of, we have to create a system that assumes that these families are here to defraud this. And there's all stories about somebody selling syringes on eBay or and we have to make sure they don't get what they deserve, or so it's a very sort of suspicious system that doesn't trust families, does not respect the fact that they have as much stake in having a sustainable system that is not abused. Maybe they have more stake in that than anyone else. So that is where sustainable solutions come from. I think it starts by trusting families, trusting and also respecting their expertise. There is clearly a knowledge distance between, say, me as a clinician and the patient when it comes to a sick child and what treatment is needed. And I acknowledge that, but there is a knowledge distance between me and the parent when it comes what kind of syringe works for them. And I have to respect that expertise that they have and make sure that they get what they need, because I don't know what they need. So that's sort of the attitude that we have to come up with to know, as we set up, how do we make sure supplies are provided? And many of these items, and we got into discussions of, diapers and that don't stick, and colostomy bags that don't fit the stoma, etc. All of these things. Many of these things are not high dollar items. They're supplies that are not very expensive. There's a lot of waste because someone else who doesn't know a thing about what it takes to do this right is making a decision about what brand, what quantity, and what size goes to these families. So this is just sort of the broader thing is, can we really imagine how we allow families to get supplies that they need in a way that is not this complicated?
And you actually came up with a few solutions towards that end and recommendations that you had shared back. Do you mind sharing what those were?
Yeah, I think
sense?
it's an ongoing process, and it's been very heartening to see that our HHSC colleagues are invested once they sort of got to hear the stories in these granular terms. And I'm 100% convinced that it's the stories that led to people coming to the table. We are meeting with the DME companies to also understand what it is that is covered or not covered, and whether or not, is there specific HCPCS code for a brand or not. And, some of the discussion was none of us right now, all of us in our daily lives, get our supplies the way we used to 5 years ago. We all know exactly what we need, and we go online, we order them, and it gets drop shipped overnight. So this is a pretty humiliating experience for, these things that they need to keep their children well, has to go through all this paperwork and justification every 6 months, letters of medical necessity, etc. So we're proposing, can there be a dollar amount that can be allowed? And we can just have an interface for the families to order these things as they run out, and you can potentially audit this. These are some of the discussions that are happening. So it would potentially could lead to a policy change, even at the MCO level. We're not there yet. We're sort of, the next step is to understand from the DME companies and from the utilization review folks in the MCO what the process is, what is actually allowed by Medicaid policy, and what can the oversight look like. But it started with essentially asking the question, an open-ended question to families, and respectfully listening.
Yeah. And I love that what you're getting to is things that are also the streamlining, trying to make things more efficient, reducing waste, because it sounds like there ends up being a lot of waste when things that aren't needed or are given. So I think that your points, as we hear Rahel speaking to it, that this is something, the elements that are at play here, it's the case of syringes and supplies, but it really applies to whatever you might be looking at. We decided to focus on this, but there was also another example in relation to home health and thinking about that. It really could apply anywhere that you're looking at care delivery in any dimension. And the other thing that I would love to point out is that The difference that we saw here, that people, when we were planning for this, Rahel really gets away from a checklist idea and what can feel to people that are experiencing it as people with lived expertise, as token participation, versus really a deep, what we're calling radical family partnership, and what that needs to look like, and how that drives technical solutions and drives co-design. And with that in mind, I am now going to hand it over to Jeff to be able to help us think about what are those elements of sustainability that we need to have in mind to be able to drive forward and what we know needs to be sustained and for families and for everybody's sake. Here you go, Jeff, take it away.
Thanks. It's an honor to follow Rahel and to see so many people on here who I've learned a lot from as well. I'm going to give a shout out to my first colleague in this journey, who's Carolyn Allshouse, who's also on. I want to, before I go into some of my slides, I just want to say a few things just to build off of what Rahel has said. By listening to families and truly sharing power. I mean, I'm a pediatrician, so I was always on the end that was, you have a lot of power over how the system works if you think of it that way. But the reality is that there's this huge amount of joy in sharing the power and the authority with family members. And that's actually, I think, what all of us really want deep inside. And so I really want to say that I think that the stories, whether it's a story about syringes or home care, or in our first stories about in Minnesota, were really around just some simple access issues for families. The stories really allow for empathy transmission. And I think that transmission of empathy is key to sustainability. You don't really get stuff done if you just present people with facts and demand things, but really you have to help and bring people into for the families to be powerful, and then for the policymakers to see the families and themselves as being able to make this work. I'm going to talk about, I just have a few slides. I really want to talk about a framework that is in the policy world for addressing sustainability. And this is something that we've circulated around for a while, that really there are three things that hold up the stool that's sustainable and equitable care. And that's having the right care model. Rahel certainly has that, and I'm sure I know there are a lot of other examples out there. That we have measurement, and I think Rich and I will both spend some time talking about how to identify the level of complexity and measurement and outcomes, and then also about the funding. And funding is what everybody thinks about first about sustainability, but you can't have the funding until you have a care model and measures that work as well. So if you go to the next slide, I put this, and some of you may have seen this from before, but there are a lot of steps to get to quality of life and well-being for our kids and the families. And it starts with adequate insurance. We could spend hours on any of these topics. And then adequacy of service coverage. I'll point out that there's a new letter from Medicaid that outlines the responsibilities of states around service coverage. Access to services, you can have coverage, but you may not have providers. Integration of service quality, and then health outcomes, and then quality of life and well-being. So I think we have a lot of steps to go to make all of this work. And I really think that we have to, sometimes we jump to service quality when we have to think about how much of a hassle the adequacy of insurance eligibility is, for example. So I think we have a lot of steps here. And I think that by articulating these steps, we can figure out where we need to act. So we could, so I think that that's really important as well. I put in some things here just for a minute about measurement, because aligned with the last slide, we really have a need to think about our measurement perhaps a little differently than we have. The way we have like great measures in the Medicaid core set, and we have other things we'd like to measure. But I think that measures really fall into different categories. And I'm going to propose that we think about the measures that we propose for outcomes this way. Surveillance measures are things that are population-based, low birth weight, high school graduation, that are really multifactorial. There are a lot of measures of accountability that are primarily attributed to one aspect of that healthcare line of sight I just showed you. Measures of access, adequacy of networks, burden of authorization and case management really belongs either to the state or to the managed care organization. And measures of process quality, which is also a lot of what we measure, are really clinical processes and care that can include care coordination and integration. And these are all things that we could attribute to one part of the system primarily, and that's where we measure for value-based purchasing for the most part, which is something we could talk about. And last, we have measures that I really want to say we don't give enough bandwidth to the need for sites that are doing great care to look at to have the ability to look at their own quality measures. And then these quality measures are things that can be used for rapid learning and improvement. And I don't think that at the macro level, we have a lot of business. We have a lot of business to say that you ought to do quality improvement, but we don't have a lot of business at the macro level saying what quality improvement you should do, because that's where we empower the families and providers. So this is where I think we need to think about more as we move forward in these models for sustainability. And I think that I brought this up so when you're talking to policymakers, you may want to at least understand where the accountability and quality improvement can really occur. And my last slide, if you go forward, is that all of this moves in a way that is slower than we'd like it to, but it moves forward if we work on it. There's a term that I've been throwing around for a long time that's that actually I just read went all the way back to the suffragette movement, which is unfortunately less than 100 years old, but is like 95 years old when women were working on getting the right to vote. And it's radical incrementalism. It's pioneering the activity, developing conditions, proving value with a line of sight, and then persistence, shared stories, skills for policy implementation. I think if we can think about what we do as moving incrementally forward, and I think Rahel's story with trying to figure out a way to get syringes purchased is an example of that, where you can just say, can we move something forward? And that has a couple advantages. One is it takes care of an immediate problem for families. The other is it builds a coalition because you've done something, you're successful, and you can then move to the next step. So I'm going to stop there. I'm going to turn this over to Rich, who's going to talk more about, Rich and I have been thick as thieves in this work since we were teenagers, not quite, but a long time. And Rich is going to talk more about sustainability and complexity and measurement. So I'll turn it over to you, sir.
Thank you. And I also want to acknowledge the privilege of being invited to be on this faculty and the number of mentors of mine that are on this webinar, especially my colleagues and Family Voices. Thank you so much. So I'm actually going to try to continue this arc of the discussion from Rahel talking about the process, going upstream, asking families for support, and then translating that through. Jeff has just leveraged this notion of the three-legged stool. The C to sustainability, but it's also has to have the patient, the family, the caregiver as the seat of that. And then I want to talk a little bit about what the approach is, and I'm going to start by telling you the takeaway. Quality measures that are necessary but not sufficient. Let's go to the next slide. This has a little bit of an animation. Several of you, and I think there might be one more click, Mitra. Yep. So many of you may already know Kristen Lind, and this is Gabe a few years ago. Gabe is now a young adult, but Kristen and I were doing a care coordination measurement project a while ago, And she was always taking phone calls, going to meetings for Gabe. And I said, what does your life look like? And this is the village. And it became known globally as a care map. I wanted to bring this for level setting, right? So all of the medical stuff is in the left lower quadrant, but the things that make Gabe a child inside of a family, inside of a community, involve these other sectors and settings and disciplines and family to family. I won't read the slide to you, but just to be mindful that we are talking about health overall and not just the medical. Next slide, please. This has also got a couple of clicks, Mitra, so go ahead through this. Thank you. So complexity is multifactorial. It's important for us to understand that there's medical complexity. We did an analysis in Boston here. You can see now, probably about a decade ago, looking at kids with complex needs. And at the tip top of the pyramid, let's call those the children of medical complexity, the top 1.5 to 2%. These are kids that had neurodevelopmental disabilities, autism and comorbidities, significant psychiatric and behavioral issues, hematologic and oncologic problems, technology dependent, significant social risk factors, multiple adverse childhood experiences. Those are the so-called CMC. And then the middle of the pyramid are kids with chronic conditions, depending on the state. This number can be, from 18% to 50% or more. And I would just call out with the federal definition of child with special health care needs, the at-risk category, that number is conservatively north of 60%. And so I really wanted us to think about the needs of families and caregivers of CMC. We do not have the ability in pediatrics to have half a dozen high priority diagnostic chronic condition categories. That is an opportunity and a challenge. Let us go to the next one, please. So I want to share a paper from a dear friend and colleague, Mary Applegate and others. You've got the citation there from Academic Pediatrics, but it's also been published at National Academy for Science and Engineering in Medicine. And this is this alignment framework thinking about improving population outcomes. It's a busy slide, but the right side of the slide is where we will get to the distillation. But for now, what I want us to do is to think, really building on what Jeff Schiff had just talked about. At the macro system, state and federal level, what are some of these mandates, setting priorities, directing resources, regulatory requirements, and overall financing? And when you look across a nation, most of the time, fewer measures are more desirable than many measures. Let's go down to the bottom now at the micro system. And look, you can see that there are many more measures at that level, some of which are reflected back up through the meso system and all the way up to the macro system. The goal for those of us that take care of children with complex needs, medical complexity, behavioral complexity, developmental, social complexity, etc., we need to think about how do we identify the right measures at each of these levels? How do they harmonize at the micro system, at the meso system, and at the macro system? And can we identify those that have that line of sight that Jeff Schiff was just talking about? Patient, family, caregiver engagement, prioritization, and what would that look like and how would we implement that? So let's come over to the right side of this slide that I built in there. So at the top of the slide are some federally mandated measures. There's the Medicaid child core set. There's a health home core set. There are the Title V national performance measures, national outcome measures, and the evidence-based, evidence-informed strategic measures. We've got links for you on a subsequent slide if you'd like to see what they are. But those are out there and they can inform some of the issues that we were talking about, setting priorities, directing resources. I'm going to take a full 60 seconds on the EPSDT, early periodic screening, diagnostic, and treatment. The recent memo, September 26, 2024, to be precise, out of CMS to the nation. None of that content is new. It is an affirmation of existing requirements for access, care coordination. It includes the activities necessary to transition from pediatric to adult care. It includes use of telehealth, strong focus on behavioral health, as well as a focus on children in foster care. So the EPSDT recent affirmation of the state health official letter, the so-called SHOW, is a strong in-hand resource to begin holding systems accountable for equitable access and equitable care delivery. Very process-oriented, but nonetheless, mandatory services for children and youth insured by Medicaid. And then finally, measures informed at the local level that can reflect local priorities. So who are some of the rights holders? Well, the patients that receive their care, they're at Dell. Their team said, let's ask the families what's important. So how powerful is that story? It might be syringes in Austin. It might be food in Butte. It might be school attendance in Duluth. But the bottom here, the microsystem, is where a lot of opportunity exists to make sure that patients, families, and caregivers are measurably included upstream, and the impact on what their prioritized goals and aims would be can also be assessed. And so that, let's go to the next slide. I think I'm just, so domains of care integration. We hear that term all the time. Care coordination is one of these domains, but it is not delimited to that. There's a patient and family experience, there's experience of the providers, and there's utilization, total medical expense, looking at admissions, readmissions, and emergency department use. So let's go to the next slide. These are resources that are, all of the resources for care integration and care coordination are freely available in the public domain. I want to specifically tip my hat to the Lucile Packard Foundation for Children's Health that funded the creation and validation of the Pediatric Integrated Care Survey, a validated experience measure, and also to HRSA, the Maternal and Child Health Bureau. All of these tools are freely available for everyone, whether you're operating at the micro, meso, or at the macro level. I think that's it, Mitra. Yeah, I won't read these links to you, but you can see we have, you have access to what do they mean by the Title V measures? What are the health home measure set, and what are some of those core measures? And I'll end by saying what I said at the beginning, necessary but not sufficient. There's nobody on this call that would say that the health home core set or the Medicaid core set is perfect for children with medical complexity or even kids with special health care needs. They're not perfect. But imagine if we know who those kids are, and then we look at what their access is to the services, we can begin to define opportunities for quality improvement. So I think that was my last slide. I'll hand it back to you, Beth Lynn. Thank you.
Wonderful. Thank you, Rich. Thank you, Jeff. Thank you, Rahel. As I've mentioned in the chat, these resources will give you a PDF of the slide deck. It will be on the website so you can explore at your leisure. I'm going to go to the next slide, please. And we want to just take a moment to see if anyone has questions. I just want to say openly that I feel like I've learned so much from everyone here. I've over the last 7, 8 years, and that there's a point where it was like, what are you talking about? So please, if there is anything even basic that you want to be like, I just am trying to understand this, we're very happy. I know they're extremely happy to be able to have that conversation, especially when we're all interdisciplinary. People come from different places and different pieces of jargon and ways of thinking about things. So let's open up to any questions that anyone might have out of your own curiosity that would help others as well. So I do have one question. If there aren't, I know I would imagine there are people that are just trying to process and take everything in, which I can also completely respect and understand. I was wondering, I'm thinking about after you've all spoken, and if one of you would want to speak to what it's hard until you're getting into the sustainability piece to understand really what measurement does for you. Is there anyone that could kind of talk to the way that creates it's a very important leverage point, it's a critical piece of the puzzle to getting to sustainability of things that matter?
Flynn, I'm just going to say one thing, that sometimes we look for the perfect measure and we spend a lot of time developing the perfect measure and I'm going to say that it's sort of like process. If you have a club of 3 people, you don't need to elect a president, a treasurer, and a secretary, because that's too much process for a club of 3 people. But if you have an organization of 1,000 people, you better have those things. And I'm going to say the same thing about measurement. The measurement has to be sufficient to tell a story that people can act on in their best faith to make an improvement. And I feel like sometimes we get paralyzed by trying to roll everything up to a big national measure, when Rahel's qualitative measurement, if I'll use those terms, of the input from the families about syringes was a sufficient enough thing to say we ought to try to figure out how to act on this. So I think we have to, my slide about where the measures fit is really about fit for purpose. So I think we ought to allow ourselves to be proud of the measures we do that we subsequently use to act on at whatever level that is.
Meg.
Just wanted to follow up on Dr. Schiff's wise words and remind us all that in quality improvement, small tests of change don't need big data. We want to try to understand what's happening on the ground level for the individuals who are most impacted by what's happening on the ground level. And you don't need a 47,000 page survey to try to determine that. So fit for purpose is incredibly accurate and makes a lot of sense to me. And coming back around to where we started in this conversation, making sure that there is family or beneficiary or enrollee or otherwise impacted individual involved, that perspective involved in designing the data collection, the measure, the modality of the data collection is incredibly important. It's going to help with your response rate. It's going to help with the accuracy of your data. And it's going to help you in the end be able to tell a story that is meaningful to all kinds of different interest holders, including policymakers and payers. Thanks.
Thank you. We got a few things coming through in the chat. I see some questions. I want to point out that we've got just a comment around using Rich's training about care coordination, but they're not being that they are there for home-based services. So I think that's a fantastic point of need and to look at, and you're not alone. And I'm not sure that's going to be getting any better, which is why we're going to really need to dig into local solutions. And then I don't want to, so much of this we could spend like a whole webinar talking about. I've got these conversations around life experience and needs. Who are the individuals asking these questions? Do the researchers look or share similar experiences as the participants? So I don't know, Chantel, if you want to come off, and I think I know what you're asking. I think that's part of why we're talking about having to do radical family partnership, because the people that are trying to come up with the solutions for these systems problems aren't necessarily and having similar experiences. But can you share if that's what you're getting at with that question?
I am, just because I currently participate in I would say it's a participatory, like, I want to say like council in sort of a sense. So instead of us doing research or even getting involved in research, we try to really dive into like, well, who is this serving and how can we bring in the community to best serve, like we may think that this particular grant or this particular initiative is a great idea. But we need to bring others within the community to actually be a part of that conversation before actually taking on the research or even taking the grant funding money.
I mean, that is such a fantastic point. I'm so glad that you came off mute to clarify that for us. And it goes exactly back to what the family faculty said, which I've got to find the exact thing here so that I've got it. And it is, what are we sustaining, for whom, and how? So that you're starting right from the beginning, before the get-go, instead of assuming any piece of that along the way. We've got a lot going on. I love this. Are there any ways for physicians to extend medical appointments for children with complex medical needs without losing eligibility for reimbursement? I think that is a fantastic question to raise. And we're asking that's a very specific question. And what I'd love to do is just allow us to hold that and know that that's a really important part of thinking about how you're going to sustain in systems and what that would need to look like. I don't know if we can use that as an example of what you would need to do to be able to figure that out, or if there are any examples of ways that's been figured out from Rahel, Jeff, or Rich to be able to share.
Bethlen, I just want to say that extending appointments is part of this need for more resources for care coordination, obviously. And one of the things I think we've been talking about is finding the truth from families and how that's valid. I have for a while with groups like this been advocating for bringing the policymakers into the conversation early and not at the end when you say, okay, I just want you to pay $500 per member per month for this group of kids. It may be much more effective for them to hear the stories. The stories are where the truth comes out. You can add data to the stories, but then that way they can be involved in what somebody texted me privately as human-centered design. They can understand how and what the processes are. So I'm just advocating for thinking about those models in an effective way to get policy members involved. And the other thing I just want to say is, I think I'm always an optimist, but I think there are states that are really making progress along these lines. At the CMC coordinating center that we're doing at Academy Health, we're trying to document some of those examples so we can really bring them back around to say, this is how Hawaii is doing it. This is how Texas is trying to do it. Because there's some real good examples of progress that are being made that are working on getting those resources up. So I'll stop there.
Rahel.
Yeah, I think to speak to the extending medical appointments question, I think we've had, it is very clear, everybody who takes care of children with medical complexity knows that it's the standard traditional consultative model where you come to the doctor's office and say what's wrong and get a prescription, etc., and even a preventative visit for a typically developing healthy child does not work. You kind of have to organize your team differently. The flow has to be different. There's got to be a whole lot of pre-work that has to be done before they even come, reviewing every specialist who had seen them in the last 6 months, let's say, and every hospital visit and emergency department visit. Coordinator calling the family a couple weeks before the visit to prepare them, to figure out what's most important and which individuals, which specialists do you have questions from, so we can get input. So we had, for instance, organized all of this into different workflow diagram, worked with our families to define it. And it is one big episode of care, but it has like 4 different components that happen over the course of a month, and have negotiated a completely different payment scheme twice a year. We're going to see these again. We didn't think a once a year preventative visit is enough. A lot happens. 6 months would be ideal to sort of update the care plan. It could be sooner if more has happened. And we have had MCO partners who are willing to test this out. The challenge is that you have to immediately show that because you did all of those things, what is the outcome that changed? And everybody jumps to, did you decrease emergency room visits? Did you decrease hospital days or hospitalizations? And this is sort of a non sequitur. For those of us who've been doing this for years, there aren't a whole lot of, after you optimize things, there's not a whole lot of preventable emergency room visit, because there are certain number of emergency room visits that are necessary because the children are complex, they're fragile. So the challenge again in the measurement is you have a small population and you have a bunch of outliers. And when people are very focused on short-term dollar savings, that's clearly not the outcome that would induce people to support a model of care that works for families and is comprehensive and, again, in the long term, better.
And Rahel, one of the key things that I in other conversations I've been in around this is that when we're talking about care that is humanistic care, that's human design, human-centered, this is also, it's a mutuality with providers, with practitioners, that they're also experiencing the secondary and similar moral distress around what they're, like the way that the system is just structurally squeezing everybody and squeezing the ability to give the kind of care that you want to be able to and need to be able to give. There were some great comments. And Chantel, did you want to go or are you good?
I'm fine, thank you.
Okay. Sandra or Sandra?
Hi, Sandy.
Hi, Sandy.
I also cover newborn screening, and we just had our 60th anniversary of newborn screening in New Jersey. Our commissioner is a physician, and we brought families to our 60th anniversary party, in a sense, to talk about their experiences once their baby got screened, and then all the things that they had to do for years in terms of all of the appointments and all of, the myriad of things that the families went through. And I think our commissioner, she's a physician, and she knows she kind of knows the diagnosis, not her area. But it was amazing to see her have emotional response to, oh my gosh, what do they go through? Like the life and death of some of those kids. And then just the amazing journey that some of them had to go through. I think they don't get that part. And they don't get that you know, for newborn screening, you know, we were just talking about like the rule of N of 5, you know, do we report something, do we not? And so we've been talking about like, these are very rare things. They're very complex kids. They're very, you know, and every family has different scenarios. Every family has different situations. Every child, even though they have the same diagnosis, may have very different experiences, right? And it's those complexities and those nuances that I think we need to drive home to policymakers to say, and I always think about like, we need a boutique method to this. It can't be cookie cutter. It can't be off the rack. It can't be one size fits all. We have to go to what does this family need and provide trust providers, trust families, and trust the state offices to provide services, you know, so it's not just this QA person who's in the back room going, oh, you've had 4 visits. Sorry, you can't have another for 6 months. You know, like that's not, when they meet these families, they see how complex the kids are. And that says a lot. That I think was important for our commissioner to see.
Yeah. Sandy, I think that's fantastic. And you see lots of head nods. We've seen some Title V offices have a fantastic strategy of having an interview with a family member and recording that, and then bringing that to meetings with various partners and being able to have questions for them to have in mind and then discussing with them after. So they're having an understanding of what this looks like in the lived context of it in reality, that then they start to be like, oh, we can't have that. That doesn't. And from what I understand, and Rich, Jeff, Rahel, Meg, you can tell me differently, but from what I understand, when you put that in front of people, families and children, and particularly in CMC, that does not seem to, at this point, be a politicized issue. It ends up being a what can we do to figure this out issue, which gives me hope for how we move forward. I love seeing everything we got in the chat. I love the conversation we've been having. We had some discussion questions that we're going to keep in the evaluation for you to be able to consider if you have any thoughts on them. We really, as I said, we're providing seeds of ways of how to think about some of these things to help spark and move you forward. So I'm so grateful for everyone that was here to help us to do that. One other thing I want to note is that those coalitions and that local work, we were saying, we recognize how important that's going to be as we move forward. And from what I've seen, I've been studying this a little bit in my own time, is that those coalitions and finding out what's locally and then really connecting to a national network with local champions in each place so that you can then really create a coordinated effort that's really setting up that infrastructure so that when the moment comes, boom, you can really level up. So I just want to mention that. And I'm going to ask Mitra to move down to 2 of our final slides. Next slide, Mitra, next slide. Those discussion questions on the evaluation. Jeff, I hand it to you to be able to share this with us before I just bring us home. Go. You bring us to the end.
Since some of us are aging faster than others, this is a motto that I like to live by. Some of you may know it. But it says, you're not obligated to complete the work, but neither are you free to abandon it. You know, in our lifetimes, we will not get everything to exactly where we want to go, but we serve our families and we serve justice by continuing to work at it. And it's an honor to be working with all of you on it.
Amen to that. Thank you, everybody. So we are going to the next slide and just closing out in the final minute. This was our last webinar, but there is one coming up through Academy Health, so we're not done yet. They've got the Enhancing Systems of Care for CMC initiative. So that is, I'm going to put in the chat how you could register for that if you'd like to check that out on, is that tomorrow, Friday? So you can join them. Next slide, please. And I put the link in the chat box for the evaluation, so you can get to that as well. And you can contact us anytime. We are going to be, from this series, creating a mandate to action from all the amazing discussion and feedback and reflections that you've been giving us. So please stay tuned. That will be coming out in the new year. We'll be working with our faculty and with our family faculty to make that happen. I just want to thank everyone today for your absolutely fantastic input and time. And we are in this together, that's for sure. And so I'm really grateful for this community. And I wish you all the very best. And I'm sure we'll see you around. And here's that link to the Academy of Health webinar.
Not done.
Yeah, we're not done yet. All right. Thank you,
so
everybody.
much, Bethlyn.
Thanks, Mitra, for being the master of the slides.
My pleasure.
And thanks, everyone, for being on this journey with us through the series. So appreciative. I also have to thank Meg. Did I get to do that? People are leaving. Shoot. Meg, my fearless partner. Thank you for everyone that's left for me to be able to say thank you to you.
Gonna stop the recording now, Bethlyn.
Yes, please feel free to.